So I don't have any disclosures. So I'd like to start with a case, and some elements of the case are on purpose. So this is a 12-year-old girl who was healthy and starts basically developing fulminant colitis with a 2-week duration. So you'll see that she has many stools a day, urgency, tenesmus, wakes up at night to pass stool, has abdominal pain that interrupts activities, and is fatigued, napping during the day, decreased appetite, and has lost weight. So when you look at this patient in your office, she looks pale, chronically ill, is tachycardic, and her abdomen is diffusely tender, mildly distended, and the blood work is on the slide with anemia, high white count, high platelet count, and a low albumin. So you do a due diligence and send the stool for pathogens, especially because of the short history, and the usual GI pathogens are negative, as well as a C. difficile toxin assay. You do a colonoscopy, and the colonoscopy shows pancolitis, Mayo 3 endoscopic score, normal ileum. You have time to do a small bowel study through imaging, and the small bowel looks normal. So at this point, you say, what do I do? And we do have guidelines published by a joint committee of the ECHO, ESPGHAN, and the Porto IBD Working Group. And the guidelines are clear in that if you think about second-line therapy, surgery must always be seriously considered. So you call your trusted pediatric surgeon colleague. They meet with the family and say, yes, we can do surgery to treat this disease, but there is a few things to talk about as far as possible complications, and those include pouchitis, the uncertainty about the diagnosis. Some of these patients will actually have Crohn's disease, not ulcerative colitis. Some fertility issues down the line, which are significant enough that we have a session on the adult side dealing with this issue specifically. The fact that the rectal cuff can develop cancer in the future, and that the patient functional outcome is going to be to pass 6 to 8 stools a day, including some nocturnal stooling. So you're the parent of this previously healthy 12-year-old girl who has an acute history of 2 weeks. And the surgeon comes in and says, congratulations, your colon is coming out. So what is the family reaction? Doctor, please save her colon. So you hear the mandate of the family, and you get ready, you get set, and you go. So you start this patient on IV methylprednisolone, and some of us would do it twice a day at 1 milligram per kilo, up to 40 to 60 milligrams in 2 divided doses. Others would do a single dose a day. And then you check your heart rate, which by now has matched the patient's heart rate, but you try to keep calm and you cross your fingers hoping that this is going to work. And how do we measure success? Well, we do follow the Pediatric Ulcerative Colitis Activity Index, which you're familiar with, has 6 domains. You score the domains in this child, and her admission PUCI is 85, which is about the most severe that you can have. But we also know that if the patient is doing well with IV methylprednisolone, you can probably successfully discharge this patient in about 3 to 5 days. And if the patient is not doing well, then you can offer second-line medical therapy only. And that is guided by the PUCI score at day 3. So if the PUCI score is more than 45 at day 3, you know that you need to have an informed conversation with the family concerning medical therapy and other options. And if the PUCI is more than 65 at day 5, you know it's time to implement that second-line therapy. Now, there is some wiggle room if the score is intermediate and you can prolong steroid use as necessary. So in discussing second-line therapy, there is a few things that must be considered. So first of all is outlining the benefits and risks of second-line therapy, because medical second-line therapy is not necessarily benign. So those risks need to be outlined to the family. There is some homework that is better to do early in the course of the disease rather than later. So knowing viral titers and a history of exposure to tuberculosis, PPD, quantiferon gold, and a chest X-ray if you have any questions about the results of these screening tests. And I guess if you're in the Ohio, Mississippi Valley, ask if you've been in bonfires. You may consider a sigmoidoscopy at that point per guidelines to screen for CMV on histopathology. And you may repeat the C. difficile toxin assay, which, as you know, sometimes can be negative upon first screening, but then show up on second screening. Now, as far as the dosing of second-line therapy, it's important to consider, and I think a lot of us are moving toward higher dosing and even more frequent interval in a patient who is acutely ill, like this patient. And why is that? Well, there are three things that seem to occur. So the first is that there's a high TNF burden. So TNF is acting as a sponge and will mop up the anti-TNF agent. Secondly, the reticular endothelial system is going to process those immune complexes and will destroy the biologic agent. And thirdly, more recently, it's been shown, and Bob commented this yesterday, that really the mucosal levels of Infliximab are most important. And this is evidenced by the fecal loss of Infliximab in patients who are non-responders, which is the NR curve on this slide. So here is a study showing the effect of accelerated dosing versus standard dosing of Infliximab on colectomy rates. And on the left of the slide, you see the survival curves for proportion of colectomy-free rates upon therapy. In the acute situation, you can see that there is hope that you can rescue these patients from colectomy. On the right, however, you see the more prolonged follow-up, and the curves tend to even out. So even though this is an approach that offers a rescue option for patients, it might not be perfect in the long term. Now, my colleague and chair of the session, along with Dr. Baldasano, Dr. Busvaras, published this pioneering paper on another option for second-line therapy, which is oral tacrolimus. And the dosing guidelines are stated on the slide, and those of us who sometimes use this therapy follow this kind of schema. So you want to target to a level of 10 to 15 nanograms per milliliter in the acute situation, and once the patient feels better, you may wean down to a target level of 5 to 10. But again, this seems to be effective in the acute situation, and over time, the colectomy-free rates can stabilize at about 40%. And these data in adult series have been panned out almost exactly the same. So I'd like to set up Dan with this next slide. And that is that we do have a responsibility to our patients. And even though I'm supposed to be on this difficult side of the argument, I would say that the worst outcome is died with an intact colon. Thank you.